This is Alissa.
And this is Chelsea.
Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey. All right, it's just me and Chelsea today. Thanks for joining us on the pod. Unfortunately, Caroline and Evie are not able to make it. So tell me what's new with you, Chelsea.
So we just finished celebrating the holidays. I had to work the holidays. So it was a bit of an adjustment this year. My grandmother passed September 17th of this year, so just a few months ago. It's our first Christmas and New Year's and Thanksgiving and such without her. So just navigating that. But since then, I started a new travel assignment and I'm gearing up for another semester at Duke University. And no new hobbies quite yet. You have to check with me in a couple of months with New Year's.
How would you even have time with everything else?
I am trying to get back on my A game with trading. So very much still into that, and then NFTs and things of that nature. Yeah. And I'm hoping to start making maybe travel plans for 2023. Who knows? But putting travel on the back burner until this variant starts to level out somewhere here. So I saw the new Spider-Man movie a couple of weeks ago at the Alamo. So that was fun.
How was it?
Amazing. I'm not going to give away any spoilers.
Good.
But it's a really cool video. Love Marvel. Love the concept. So
me too. First, I just want to say I'm sorry about your loss. I understand grieving around the holidays. So I'm so sorry that you're having that experience. I think there are a lot of people who can relate to that. Got to stay home with the family for Christmas. This time of year, typically our education department slows down because nobody's around. Nobody wants to learn things. Nobody wants to come to class between Christmas and New Year's. This is a slow time for me, which is really nice. I am in between my quarters on my program, which is also really nice. So still working on my PhD, which I love. People think I'm nuts, but absolutely love it. But I also haven't done any traveling. I'm too scared. I'm too nervous to make plans because every time you turn around, there's another variant. The new variant isn't super strong or present here in my state, but have you had a lot of experience with it where you are?
So far, we've only had, I think, like maybe one COVID patient in my hospital, but the hospital I work for this new assignment is super small. But I agree with you. I've put a lot of my travel plans on the back burner, just buckling down.
Yeah, it's nerve-wracking.
Up on like food and water and committing myself to just personal projects at home right now.
Absolutely.
Because you're so correct. Like every time I turn around, there's a new variant. At one point, I was like getting to the point where I was comfortable enough to eat out again, but I stopped that.
I know.
But we're right back to where we were. And all these breakthrough cases is really scary. Fully vaxxed, so both shots and boosters, and still getting breakthrough cases because the Omicron variant is just so transmissible.
Normally, we travel around this time of year for the holidays, and I was trying to be brave and bold and think about making those plans. And I just want to spend my holiday on a beach. And then I just couldn't bring myself to do it. And then I feel like, see, I knew it because there was another variant that came out and borders are being closed down again and stuff. And so I just feel like pat on the back. Yes, you should not be traveling right now because it's just not going away. And so, I just can't bring myself to do it.
I think the biggest thing for me is just focusing on what I can do. Like I can go for a drive. I can go to Starbucks. I like to go, like a lot of times if I go to a movie theater, you can see how many seats are reserved. So you take either a really early movie or a really late one because there are less people there. I think finding a workaround has definitely been my saving grace with the pandemic and needing to just adjust how I go about like my usual activities.
No, that's very smart. Finding those workarounds. All right. Today, we are here to talk about what we do when our patients don't want to cooperate with treatment. I know I'm very familiar with this concept. I assume that you've had some experience with this too. Do you want to kick us off?
Sure. Maybe a little too much experience.
Exactly.
I always find myself in a gray area when I talk about patients who are refusing treatment. We often label them as non-compliant. I do a lot of elder care. So a lot of the patients that I take care of are 65 plus, often have dementia or altered from sepsis or a UTI or something like that. And so when they refuse care, my first step is to determine whether or not they have capacity. Let's get psych involved. Do they have capacity or not? Let's get the family involved if there's family available. If we have permission from the family or a POA to treat them, then they have to be treated. So that's my first line of defense, is determining if the patient has capacity. If the patient does have capacity, because we get a lot of alert and orient times for patients who do refuse treatment, then it's to educate the patient. This is what will happen if you don't receive this treatment. Here are the risks of the treatment. Here are the benefits. And they make their decisions from there. I think that's the hardest thing about being a nurse, because you're invested in the outcome of your patients, because you're there to save their lives, essentially. So when they refuse treatment, it can be upsetting. But at the end of the day, you've educated your patient, who is alert and oriented ×4. And you have to be willing to divorce yourself from their decision, which is also hard as a healthcare worker.
I think you nailed it. Finding out the why behind the what, I think, is incredibly important. Why are they refusing care? Do they understand the risk versus the benefit? Do they truly understand what they're refusing? I think all of that is incredibly important to assess of our patient before we accept that they're refusing care and they're non-compliant. We throw our hands in the air. If we don't take the time to work with our patient to fully understand their position and then educate to any misunderstandings or misinformation, we're doing our patient a disservice, because it is our job to advocate for them. And sometimes they are making decisions based on a misunderstanding. And so I think it is our job to be that patient advocate, not just to advocate to the physician what the patient needs, but also advocate for the patient when we're discussing treatment options with them, letting them know in those clear, plain terms, this is what the doctor's trying to tell you, and these are the experiences or the outcomes that are going to happen if you go down path A or path B. I think frequent flyers are a really bad term, but unfortunately, patients get that nickname, I guess, when they come in quite a bit. And so we did have one of those patients that came in frequently. She was an orthopedic patient, but she was non-compliant. She did not do the things that she needed to do to keep her hip surgery. I believe it was originally just a hip replacement, and then it turned into a hip infection and had to have antibiotic beads put in. And ultimately, I remember, and I think probably the reason why she comes to mind now is because I took care of her on Christmas Eve, and she was scheduled to have an amputation the week between Christmas and New Year's, and she's still non-compliant. I'm not going to agree to that. I'm not going to do any of that. Now the limb is dead. And if you don't have them amputate, you are going to go septic. Your limb is dead and it's going to kill you. And I just remember working with this patient repeatedly. And I don't know if it was a lack of understanding or if it was just this stubbornness. But ultimately with this patient, she would not consent to the surgery. And I don't know what happened to her. She was discharged. No matter how hard we tried to help her understand that the decision she was making was not in her best interest, she still refused the best care.
When I think about my non-compliant patients, they're often alcohol withdrawal patients. So patients who come in who are having alcohol withdrawal, who are having sometimes seizures from that alcohol withdrawal, and then they stay for a couple of days and they don't finish their treatment that they need to ensure their safety, and they want to leave, oftentimes an active withdrawal, and they want to leave. And unfortunately, a lot of these patients often have family members who don't want to be involved with them. So these patients come in and get treated for alcohol withdrawal, and day 2 or 3, they're like, I want to leave. And you try to do everything you can to say, hey, you can't leave. Actually, you can leave, but you shouldn't leave. We would like you to stay and finish out what you need, but it just doesn't happen. That's super frustrating because you obviously want to act in the best interest of your patient. But at the end of the day, they're an adult who does what they want to do. But it is hard to find quality psych services out here for those patients, whether they just need someone to talk to or someone to keep in touch with them or someone to, it's very difficult. I don't know if you've had that experience too, Alissa, where you've had patients that need community psych services. But yeah, and sometimes
absolutely
you feel like banging your head against the wall sometimes because you're like, do they not get it, or do they get it and not care? Or I care, shouldn't you care kind of thing? A lot of decisions that their patients make, not to take it personally, which is hard. That's been a lot of my experience from non-compliant patients. And then I said elderly patients who probably should have their capacity taken away so we can treat them is also pretty difficult to deal with. I know a lot of the times we start talking about pursuing palliative or end of life care for those patients because there's sometimes only so much that you can do if they're refusing anything, or sometimes our Alzheimer's patients, if they're not eating and not drinking, and do we put a peg in? Having those really difficult conversations can often arise when we're servicing patients who don't want treatment.
I definitely understand that side of things. So I work in an academic medical center in the middle of downtown. So we also have a very large homeless population that right as the weather starts turning, we get a lot of people who will intentionally get hurt so that they have a nice warm place to stay. But then they don't really want the care. They just want the roof over their head and a warm bed and a meal. And so we can get some head bumping with those patients and the staff because they don't want to use a urinal and they don't want us to measure their INO. They don't want us to take vital signs. They just want to be left alone like they're at a hotel and bring them their sandwich. And so we've had a lot of those kinds of conflicts with those patients. And those patients can be really frustrating because you have a staff of nurses who do care, who do want to take care of these patients. And if these patients didn't need some sort of medical care, they wouldn't be admitted. And so you have nursing staff who are invested and care and want to do what's best for people. And then you have patients who have a different motive for being in the hospital. And when those two collide, it is like banging your head against the wall because their motives don't match, right? We're not going to have an aligning outcome of harmonious care being given and everyone's happy and appreciative. You're going to have a patient yelling at them to close the door and get out of their room. And you're going to have a nurse feeling defeated, like, I can't even do my job. It's so important when you recognize that you have a patient like that who's really just there for a nice warm bed. It's not about you, right? And it's so important for us to put that professional wall up of this is not somebody who wants my healing hands or however you're looking at yourself. This is somebody who literally just wants a nice warm bed. And that in and of itself is meeting a need for the patient. It's when those patients become disruptive to the care. And we have our fair share of those patients that do come in with complex behavioral health issues. And so then they are disruptive and they're throwing urinals at people and they're crashing equipment around their room. And that's when you have to call in your behavioral health emergency team. It's unfortunate, but we now have the empowerment, I guess I should say, at our facility that if people don't want to be here for medical care and they're going to be disruptive to the treatment team, we do have that option to invite them to leave. So I don't know how to say that nicer, but yeah, if we can terminate care, if they don't want to be here and they're not seeking medical care and they're being disruptive to the process, then we can terminate their care. So that is something that wasn't available when I was a bedside nurse, but it is now. And that would have been really helpful as a bedside nurse for some of the patients that we had, but it's available now. So luckily the nurses do have that as a tool in their arsenal if they are having those patients who are being very disruptive.
That's a good point that you bring up. We also have a behavioral emergency health team that can come and help us out with complex behavioral health patients. I know we had a patient who was very disruptive with his care and started calling nurses racial slurs and being physical with us. We called the police and he was kicked out of the hospital because you cannot do that to anyone. And two, definitely not our nurses. So I definitely invite people. I think we definitely need to have more conversations about patient etiquette in the hospital. Yes, we're there to care for people, but we also deserve safe working environments. So that's
absolutely
definitely something that needs to be discussed more. Another question that came up, and how do we keep it all in perspective? I think, especially as a travel nurse, I've adopted more divorcing myself from my patients' decisions. And then two, just knowing that you're providing the best care. If you're documenting that the patient's refusing, if you're notifying the doctor that they're refusing, then you're doing your job. You're making sure that it's known that this patient does not want whatever services that you're offering, and you're doing your job. At the end of the day, that's all you can do, especially if you work with an adult population with people who have capacity. You can only do but so much. And at the end of the day, even if it is a refusal of services, you have to honor that refusal, which I know is difficult for a lot of nurses to understand. But you do what you can for that patient, and then you focus on your patients who do want the care. doing your due diligence and making sure that you're educating that patient, I think is also something that we need to make sure that you're doing. I know in our Epic, it has an education tab. And I always make sure I chart every shift what I've educated the patient on. And I make a little note that says if they are refusing SCDs post-op, if they are refusing this, that, or the other, whatever it is, I make sure I chart it and document it, and I let the doctors know.
I think the nurses need to realize or keep in mind that it's not a reflection on you as a nurse if your patient's refusing things. It doesn't mean that your powers of bargaining aren't good enough, or we all go through and we all experience a patient that is just not going to do what we are asking them to. And it doesn't mean you're a bad nurse. It doesn't mean that you've done something wrong. Every nurse gets that patient and it's okay. You're not alone. You do your best. You document, just like you're saying. You communicate with the treatment team, and then you move on. You have to have that professional wall of, this is not a reflection of me or who I am as a nurse. They're doing their own thing. It's them. It's over there. Everyone does it. Like, you have to have that professional wall of, it's them. It's not me.
Do you have any success stories about patients who were non-compliant, but then have a change of heart?
It's always easier to remember like the big fights that you get in with your patients. It's harder to remember all the times that you had those tense moments with your patients where you almost didn't get them to do what you wanted, but then they did. And so trying to think of a specific situation where I had to get a patient to come on board with me. Those are harder to remember. And just because once you get a patient to bend to your will, the power struggle or the battle's over, and then it's just a normal shift. So I think for me, it's more of clarifying misinformation and gaining patients' trust.
Yes.
And that's usually how you can do it, is whatever happened with the previous relationship with the nurse or whomever lost the trust. Somebody lost the trust. Somebody made a statement or an action or something that made that patient not trust the treatment team. Mm-hmm. And it's whatever I did that came in the room that clarified misinformation, comforted the patient, made the apologies, and then comforted them and really made them feel like, I am so sorry that happened. This is actually what's happening. I will keep you informed. Whatever it is, it's regaining that trust with that patient so that they'll do what I need them to do or do what the doctors ask them to do or whatever. I think that's the action of the success story. And unfortunately, those don't stand out as much because that's what we do every day.
Exactly. I agree.
There are those times that you're taking care of a patient that's doing everything that you ask them to, and then they have a family member come in this is all wrong. And unfortunately, that example I have for you is a pediatric patient, which we don't normally deal with, but the parents were the ones who were the problem, which I find ironic. But let me tell you, so the floor I worked on, I told you, was an ortho trauma floor. And because we did ortho trauma and we are connected to a pediatric hospital, there's this age gap where we'll take teenagers if the peds hospital is getting full. So we had this, I want to say 15-year-old kid who had been in an accident and had some orthopedic issues. After an orthopedic surgery, the best thing to do is get up and move and get your body going. And so this kid was doing really well and working with physical therapy and doing everything the nurses wanted him to do. And as soon as his mom showed up instead of his dad, she did not want him getting out of bed. She did not want us pushing him that hard. She wanted him to have more pain medication because her baby was in pain. And then his mom did really weird things, like sat in the bathroom like a cheerleader while he was trying to have a bowel movement, and just weird things like that really creeped out the staff. That mom became really disruptive to the care. And because our staff is not used to working with underage children, they had no idea. Are we allowed to kick mom out of the room? She's like in the way. Ultimately, we ended up talking to her and letting her know that everything that we were doing, the treatment plans, the getting up, the walking around, reducing the pain meds, was actually in his best interest. And the requests that she was making that had nothing to do with the patient, she was just making them, was actually detrimental to his care. I'm not really sure how well that went over. I don't remember. I just remember they had to talk to her and that the dad stayed at the bedside after that conversation. There are always those family members that think that they know better than the medical staff.
I think it gave a great example about how to approach difficult family members. So even when a patient is being compliant and family members come in and say, hey, what's going on? Or they take to Google, which is like the most annoying thing ever, getting the other members of the medical team involved. And sometimes it just comes down to having that conversation. You guys had the conversation with mom and dad came back. So that's great. So sometimes it's worth having that conversation and not being afraid to approach it in a reasonable manner.
It may have been that it was just too much for the mom to handle, to watch her son work so hard and be in pain. And that could have been why they decided for her not to come back. I honestly don't know, but you're absolutely right. Like having that conversation and just letting him know, like, it's in your son's best interest to do what we're asking him to do. And if you want him to get better, you shouldn't interfere. And so then however they decided to handle that, ultimately, I think when you're dealing with a patient who's non-compliant, there's something behind it. And while it can take a lot of energy for a nurse to try and dig at what's happening, it really is worth it to try and find out. Either they don't trust what's happening with their care team, or they don't trust what's happening with the decisions that are being made. Like they don't like the process that's being selected. They don't want the surgery. They don't want the medication. They're uncomfortable. Something is happening with your patient. So if you just do a little digging, figure out where the trust has been lost and see if you can regain it. A lot of times that can fix things. And if nothing else, you can at least have a trusting relationship between you and the patient so that you can have a successful shift. So if you take that time to figure out what happened, you might be able to bridge that relationship for at least your shift. What about you, Chelsea? Any final thoughts?
Yeah, I think that's a great recap. And I am document learns whatever new nurse learns, whenever you have a patient that's being non-compliant, make sure you document and make sure you document those patient education conversations. I think it's valuable that the care team knows that we are educating the patient, and then also gauge your patient's education level, because that's also could be a barrier about, do they understand what they're reading? Some patients don't want you to know that they don't have a high reading level. So just come to them and say, hey, what's going on? Do you really understand? It's important that we're having those conversations. But Alissa, I think that's a great recap.
And not just assessing their reading level, but their health literacy. Are we using too big of words? Do you understand what we're saying? Do we need to simplify the words that we're choosing as we talk about your care? So a lot of times we use a lot of jargon, especially when doctors are rounding. If you're in a medical center like we are, where there's 5 people rounding and they just walk in and talk to each other over the bed instead of talking to the patient. Yeah, I think that's really important that we assess that health literacy. That's a good point.
All right, guys. Thank you for listening to our podcast. We had a great time discussing these topics. I think this was a really good topic this week.
I think it was a good topic. Yeah, time goes really fast when you're having fun.
We're all out of time.
We do look forward to connecting with you on our next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address. That's amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of the Academy of Medical Surgical Nurses or review your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend med-surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN on the search field of any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Alissa.
I'm Chelsea, and always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that makes a huge difference.